Hi, I'm Annie, and I'm on the staff at NAMI, Delaware. Before our discussion begins, I'd like to give you a little bit of background on our organization. We are the state agency that's associated with the national one, NAMI, National Alliance on Mental Illness. And it was founded over 40 years ago by two mothers who each had adult sons living with psychiatric conditions. Eventually, their leadership led to an alliance that formed and grew across the whole nation. And their focus was to improve the lives of those affected by mental illness. Not only those with the conditions, but for those who care for those with the conditions. Now, if you're not in Delaware, there is a NAMI where you are in your state. You can find your local NAMI by visiting the national website at nami.org, nami.org. Now, our agency, NAMI Delaware, offers education, support, and advocacy and housing in the state of Delaware. Our programs for now are operating virtually, and you can learn more about them by visiting our website, namidelaware.org. But I want to let you know about a couple of events that are coming up soon. Tonight at 7 p.m., we have a family support group meeting that's held virtually. You can register by accessing the link here or by visiting our website. Monday, we also have a family support group meeting also at 7 p.m. Now, I'm sorry, that's Monday the 25th. Sorry, I didn't clarify that. So tonight at 7 p.m. and then Monday, January 25th. Now, next Thursday, the 21st of January, we have a peer support group meeting, and that begins at 6:30. Again, you can register by using the link attached in our comments or by visiting our website. The reason we use registration in advance is simply to keep the Zoom link private. Now, we do have another event at the end of the month, January 28th, I'd like to be sure you know about, and that is our monthly Sharing Hope Community Conversations event. This is an interactive virtual discussion that is led by our awesome volunteer moderator, Nimade Bewu. The goal of this meeting, this monthly meeting, is to discuss topics related to mental health and stigma in the Black community. In January, the topic will be physical and mental health. Each month, Nimade leads a discussion and invites panelists who are experts in that area to join in. So we hope that you'll consider joining. We want to make sure before we start talking about today's topic that you have access to support immediately should you need it. So there is a national crisis text line. You can access that by texting 741-741. And here locally, you can access the Delaware Hope Line. You can do that by calling the number on the screen. You can also text them to access support information. However, to connect to an individual in Delaware, please use the phone line. Now, we know that for families supporting individuals who live with mental illness, knowing about crisis services is really important. Knowing who to call, knowing when to call, knowing what will happen next does provide some sense of comfort and certainty in a very uncertain and unsettling time. So today, we're very pleased to bring you this conversation, and we're inviting Malia Boone and Glenn Owens, who are leaders in crisis response efforts for youth and adults in Delaware. We're so glad they're joining us today. Welcome.
Hello.
Those of you tuning in, please use the chat feature to ask any questions that you may have during our discussion. Thanks for being here, both of you.
Not a problem.
Thank you for having us.
Do you want to begin with just some introduction from each of you and your job titles, basic responsibilities?
I'll defer to Malia.
Glenn, you want to go first?
Well, go ahead.
I'll go first. My name is Malia Boone. I'm the program manager for the Crisis Program for Youth and Children through Delaware Guidance Services, the Mobile Response and Stabilization Services program. And my responsibilities are really just to oversee the statewide program. I supervise the supervisors as well as the staff who are responding, who are doing the crisis assessments and the follow-up work for our program.
Thank you.
Mhm.
Glenn?
And I'm Glenn Owens. I work with DSAM, or the Division of Substance Abuse and Mental Health. I'm the administrator for Crisis Intervention Service, which is often referred to as mobile crisis, but a bit of an older term. I don't like quite as much, but Crisis Intervention Service. And I also oversee the Delaware Hope Line, which was mentioned earlier. The staff that we have with crisis intervention are individuals trained in dealing with mental health or substance abuse crisis, both over the phone and also in person if the need arises for that. The Hope Line is there to provide support for individuals and connection for individuals who really need a little extra help, but certainly don't have something that rises to the level where they would need a crisis response.
Yeah, I think sometimes that word crisis becomes a challenge, doesn't it? I think we're going to touch on that. But before we touch on that, let me ask you about data. Can you share the impact that COVID has had perhaps on the number of those you're serving? Do you have any of that data?
I do. So in 2019, the crisis service for children and youth was actually a lot busier than we have been in 2020. We served 3,738. Well, we did 3,738 assessments. And then we had 2,875 assessments in 2020. So almost 900 different difference. And we saw a huge drop off in March when the schools closed. So we saw a big difference when the schools went to virtual or hybrid. We don't get as many calls because the schools are often our primary referral source. So I think in terms of the impact that COVID has had, the kids that we are seeing are having some very serious kinds of things happening where our service doesn't necessarily have to be a serious crisis to receive support. But those are the kids that are being referred right now. And primarily, I think, because kids that are just starting to maybe have some struggles are being managed and they're not necessarily calling. The schools used to call, but they're not in the classrooms being seen right now.
Got it. Got it. Okay. Thank you. How about you, Glenn? Have you seen a change?
Well, I've seen a couple of changes this year, and I don't have the full numbers in front of me, but I have in my head, at least I have the general idea. And what I can say to agree with Malia is that when the shutdown started in March, April, and then May, there was a huge dip in the amount of not just community responses, but also in phone calls that we were receiving at both of our sites. Once things sort of opened up again, starting I think in June, our numbers actually kind of skyrocketed from there, particularly in terms of community response. I would say that our number of phone calls and community response was pretty similar in 2020 as to what it was in 2019. But you keep in mind there's about a quarter of the year where our numbers really bottomed out and then bounced back significantly.
Wow.
I think early in the coronavirus, or in that period, people were very afraid to have anyone come to their home.
Right.
My staff was probably even more concerned to be going out. Getting PPE was hard to do. And so as a result, there were fewer calls and fewer responses. But since then, it's, as you might imagine, a lot of people are struggling.
Right.
And as a result, I think more and more people have been reaching out for help. Kids are, a lot of them are cooped up at home.
Yeah,
I'm sure that's a big part of the issue as well. Not having that structure can be an issue.
Right. And it's so important that we're having this conversation. I'm so glad you both joined us. So around the COVID crisis, is there anything your agency has done differently or anything you want to address with our viewers regarding COVID that they should know?
Yeah. So in the youth crisis services, we've transitioned to more telehealth services. We never did telehealth services at all before, so that's more of a drastic change. And some families want that more because then we're not coming in and out of their houses. And
Right.
usually when we open a crisis case, we may do an assessment and then provide services for 30 days. So during that time, some families feel much more comfortable with the telehealth service. We have been able to still provide some in person as well, but we've done a majority of our assessments through telehealth because that gives us the ability to access them very quickly,
Mhm.
no matter what's going on, even if we have more limited staff even.
Right.
So that's one thing. And then I know we've been talking about the Hope Line. And so the crisis clinicians are also doing something in conjunction with the grant, in terms of disaster crisis counseling. So we are working with schools right now to develop some, group counseling sessions and individual sessions, kind of more in a disaster crisis counseling kind of
Mhm.
response, just to provide support around COVID and the pandemic and the stressors that are related to that right now. So we're certainly still trying to reach out to counselors and administrators and things in the schools that may have interest in bringing some of that support in. So hopefully that's
So
something that.
hopefully people are watching. That's right. So, and when you say disaster counseling, I would assume you're including and using that language because of the terminology in your training. But we're looking at the coronavirus as
As
the
a
trauma,
disaster.
right? As the as the disaster, as the
Mhm.
Mhm.
collective trauma.
Yes.
Okay. All right. Thank you. And that's a very important work. I'm really glad to hear that you're doing that.
Yeah.
How about you, Glenn? Did you all do any? I know you mentioned the PPE. Is there any change that people should know about with COVID?
I th- I would say that we are still here for you as we were previously. We do have PPE at this point. I think people are a little more, I don't want to say relaxed, but are more comfortable in
Mhm.
terms of using their PPE, washing their hands, taking good care of themselves, etc. Our service is set up so that we respond to phone calls, and our first step is always going to be to work with someone through whatever issues they may have over the phone.
Mhm.
It's only usually in the more urgent times when we would respond, um, out to the community. So as far as our interaction that way goes, it hasn't changed that drastically. My staff have really um, battled through, and it's not to say that no one has gotten sick, or no one has needed to quarantine or what have you. And there are times, we run a little short on staff just
Mhm.
for health
Right.
reasons.
Right.
But um, we're staying sufficiently staffed and getting teams out there in the community when it's needed. So even though it's a very difficult time right now, we're still doing our best to get out and respond.
Well, thank you. That's great. So one thing you mentioned around the idea is that when people call, the first thing you're trying to do as a team is to de-escalate on the phone to help someone work through something and achieve a de-escalation status via that phone call.
Mhm.
What I want to address with our viewers is when to call and what a crisis is, because there might be a disconnect in who's calling when because they don't realize that they could have called sooner. Is that a possibility?
Yes.
Okay.
Um,
So let's first look at like defining crisis. Let's go there. What do you all think?
do you want to go ahead, Malia? Or
Yeah,
should I?
I'll go.
Okay.
For crisis, how we see a crisis is that's any time someone is concerned about a child or youth and feels that they may need some extra support. So I think that in the past, a crisis has been considered, a danger. There's some sort of major risk that puts the child's life or others' lives at risk. And I hope that it's very clear that a crisis just means that you guys are struggling with something and need some extra support and want to assess, see, how we can get that support in place, what needs there may be, and support you through that, initial period, and hopefully also connecting you with resources that will provide you more long-term support and help you through whatever that challenge may be.
And really, you all in the youth team, you changed your name to remove the word crisis, right?
Yeah.
Stabilization you're using, right? To try to kind of, I mean, I'm not sure why you changed your name, but it seems as though removing that word may help kind of send the message that we're here earlier than you think, right? Yeah. All right. So what do you think, Glenn? Around the term crisis.
I think perception is the name of the game. If you feel like you or a loved one are experiencing a mental health or substance abuse crisis, call us. I wouldn't say put it any other way. There are certainly there are limitations to what we can do. We do have the ability to hospitalize individuals against their will. It's a last resort for us.
Right. And to clarify, let's say that again. I think that's a really good clarification. Can you say that again?
Just that we have the ability to hospitalize someone against their will, but it is a last resort for what we want to do. So there's a lot of things that we would try, and Malia's team, I'm sure, would try as well, to try to get those individuals help before it gets to that point. So I don't feel like there's anything such as calling too soon because of crisis. You may find if you call us and say, "Oh, I'm not sure, they don't seem to be doing very well," that doesn't mean that we can't still talk to that individual, try to make an assessment over the phone, and make some recommendations potentially for treatment, for a wide variety of different treatment options, or just for support. We could even connect them, honestly, with some of our Hopeline staff who can have more of an ongoing connection with people. So I think I don't want people out there to ever feel badly or like they're calling crisis too soon. We get, and I don't want to sound facetious here, but we get calls like, what's the number for 911? Or I mean, that's a bit of a joke, but people will call and say, "How do I get a hold of social services?"
Okay.
And it's not like we're going to say, "Hey, this is crisis. You can't ask us those questions." Right. You just give them the number for social service. Yeah, I mean, it's not a it's not a challenge for us, and that's a big part of what we are set up to do.
Right. So really, I think what you said about it's not too soon is a really important part of this conversation. For those watching this video, whether live or as a follow-up recording, please hear what we're talking about. There is a crisis is defined by you. And it is never too soon to reach out for help. I often try to, when talking with folks about this concern and really anything mental health related, I try to remind people that mental health is part of health. So if you were to reach out to a doctor because you weren't feeling well and you've tried everything to resolve whatever it is that your symptoms are, and you're still feeling badly, you're going to call your doctor.
Yeah.
So isn't that the same? And you all, in essence, you're not doctors, but you are mental health professionals who can help refer to the right professionals or the right supports that someone might need to feel better. And that's really what we're trying to accomplish here.
Yeah.
And I would point out, when I say with people calling and it never being too soon, the only thing I would say is a bit of a caveat is people that call oftentimes have a very firm idea of what it is that they want for a loved one. I would just make clear that we cannot always, based on their rights, honestly, we cannot always do what a loved one is asking for with that individual. That does not mean we can't help and that we can't provide a service. You just remember you're calling us as for professional help, and so we're going to do our best to give you professional advice, professional services, and a professional referral. it's a good thing to keep in mind.
But your clients, in your case, Glenn, are adults. They're 18 or
Yes.
over. So they have individual rights, right? So
Yes.
that's a piece of this. Sure. I don't think it's, I don't want to dissuade people from reaching out at all, though.
No.
Because even if the individual that calls ends up finding that what their wishes for the response aren't what you're going to do, they should, in fact, receive some sense of
Yes.
relief and support and get connected to services that they may not have known exist.
100%.
And I would
Yes.
say, piggybacking on that, NAMI Delaware is here to support you too. And while we are not crisis responders in any way, we can come around after that and provide the support group conversations, provide the programming, provide the advocacy if needed in situations where folks just need a special additional help. But we have to all work together, and we want to make sure that our viewers know that you're here, that each of you and your agencies are here. So thinking about the caller, the prospective caller, what should they expect? What would happen when they call you? And let's make sure that we can think about what that prospective caller may, like you said, Glenn, assume is going to happen or intend to have happen. And let's try to unpack some of that so our viewers are a little bit more less worried about what may happen.
Yeah. I think that's so helpful because many times people don't call because they're anxious about what it's going to look like, and maybe they're not prepared to handle that. Or so I think that for our program and with youth, of course they can call the crisis hotline. They're going to have someone will answer right away who's stationed in our call center that's going to find out information about what's going on. So they're going to ask a few questions. And they're going to connect with a clinician. So, so the initial call that you're making is actually coming into a hotline, and you're talking to someone who's manning that hotline to make sure that we're there immediately for you. Now, sometimes there is a need for some de-escalation or support that's happening right at the point of that call. Because there's something happening that needs to be managed right then, and the call center clinicians will help with that. And then they're going to put you in touch with a crisis clinician who will then complete a risk assessment with you and your family. And sometimes in typical times, non-pandemic times, that clinician is coming to the house, coming to the hospital, coming to, your doctor's office, wherever, school, wherever that's happening. And sometimes now that might be over telehealth, which could be, video conferencing or telephone if they have no access to video conferencing at all. So the clinician completes a risk assessment, and part of our process of risk assessment is, of course, collaborating with the family about what is going to be best. There may be, just like Glenn said, sometimes where the family is hoping for an inpatient psychiatric admission, and it doesn't necessarily, either there's no beds available for an admission to occur, or it doesn't necessarily meet kind of the criteria of what would be required for admission. But there's so many things that we are able to do to support, even if that's not the case. And many families we work with sometimes think that that's the only option when they call us. And then once we talk to them about all of the different levels of service that we can connect them to, the support we can provide them with in the meantime while we're trying to get that support in place, then they're thinking, well, I probably don't need this admission to an inpatient psychiatric hospital because I have all this other support that I didn't even know was available. Right. So I think that, there's a lot of questions in our risk assessment, and sometimes people are like, oh, this takes a while, but our assessments probably take an hour to 2 hours. And then, in that process, we're always creating a safety plan. Even if they go to the hospital, we create a safety plan to make sure that they can be safe even going to the hospital. And make recommendations for services, even if after they get out of the hospital. And our crisis program has to close if a child goes into an inpatient facility. We're not able to stay open. And
so
that's
the file, you mean, like when you're serving a family? Okay.
Yep. So we open a case every time we do an assessment for a child. But if they need to go inpatient, that's a very high level service. They're going to provide a lot of support for you. They're going to create a discharge plan. They're going to do, connection to services and all that at the point of discharge. So our service would close. And I think sometimes that can be confusing for families. They're not sure if we're supposed to, follow back up with them. We always encourage them. They can call us back if they go into an inpatient setting and need more support when they come home. They can always call us again. But we would close at that point. If they don't go inpatient, we always keep the case open and support that family. And our program is overseen by Prevention and Behavioral Health Services for Children and Youth in the state of Delaware through DSCYF, the Department of Children, Youth, and Their Families. And they, kind of dictate a little bit about what we can do and can't do and, all of those kinds of things. But I think almost always we stay open for 30 days if the family wants that. They don't always want that. And provide that support and connect with resources. And the majority of our families connect with an outpatient provider or a more intensive level of service at the point of discharge from crisis program.
Great. Wow, that was a lot of information. I appreciate that. I hope that's helpful to our viewers.
Yeah.
Thank you. Glenn, how about you? What would prospective callers need to know, or what do you wish that they know?
Ditto.
Everything Malia said.
So I think when we generally get two sorts of callers, and they're probably going to get a slightly different experience. One is what we would call a collateral contact. That could be a family member, that could be an agency, it could be a peace officer, it could be a number of different people calling. In those instances, we're probably going to try to get do a risk assessment, as Malia was talking about, get the facts and the details as quickly as possible, try to make a determination about the most appropriate plan of action, what's going to help not only the individual but the person who's calling, and help them to be able to put that plan into action for the person. If it is an individual calling for themselves, or a family member calls and says, "Oh, they're right here," we're going to attempt to have much more of a conversation than a just the facts, ma'am type of approach. Our goal is to be able to hopefully build rapport and to be able to, based on their needs, develop a plan with them that is going to work for what they are expressing they want to have happen. There are obviously rare cases in which, I shouldn't say rare, they do happen, where we'll go out and we'll assess an individual in the community. Sometimes the individual will ask for that themselves. Sometimes we'll go with the request of other people. Our goal usually, and one of the reasons that we have two offices in the state, is so that usually if you're speaking to someone on the phone, that's generally speaking the same individual that's going to come out and see you in the community. I really think that's an important part of what we do, and I know Malia's agency runs very similarly in that.
So there's continuity. Is that the idea?
Yes.
Okay.
There's continuity, and if you get the opportunity to build rapport with the individual over the phone, there's few things people like less than taking 20 minutes to explain
having to rehash the story again.
Generally, it's a pretty unpleasant experience that they're having to talk about, and then, it's a whole new person that just showed up, and now
so I have to start all over again.
Right. That is a huge roadblock towards successful entry into treatment and for the beginning of recovery. And so we do our best to make sure that it's the same individuals that they're working with throughout. As far as we go, we do some follow-up calls. We also have peers that are part of our unit that will do follow-up with a number of individuals. The other option that we have, and we've mentioned it previously, is the Delaware Hope Line, which I said before is more of a number to be called for people looking for connection. And when I say that, to be more specific, it's about connection to a service, to an agency, to a type of help, and also that interpersonal connection. It's a 24-hour hotline or warm line, really, staffed by peers. And they are there and prepared to be able to help people get to um, a wide variety of help, not just mental health and substance abuse issues, but the slogan, if you've seen the ads, is life gets messy. Sometimes you need help. Call the Hope Line. So we're there to help you with the messy.
That's
as,
great.
as well.
Yeah.
And that's also something that frankly crisis intervention has done for a very long time, and we still do. So I think that for people calling, you would expect that you're going to be dealing with a professional mental health worker who is trained in crisis. Even we hire new staff, obviously, when older staff leave, but usually people are working for us for 6 to 8 weeks in the office, listening to calls,
Mhm.
going through training, etc., before they're taking their own calls.
Mhm.
They'll go out with a lead worker, if it's a community response, and watch and run. Our goal is to make sure that when people call, they are having a pleasant, I shouldn't say pleasant experience, but
Well,
as pleasant as we can
as
make it.
pleasant as possible, sure.
Yes.
Sure.
We want people to be able to feel like they can turn to us when they need our help.
Absolutely.
That's
Absolutely. And
very
that's really the goal of this whole conversation. We want people to
yes.
know where they can turn when they need help. I can speak from personal experience that when you have a loved one in your household who needs help and you don't know how to do it yourself, it is so frustrating and scary.
Yeah.
And how I wish I knew about your agencies back then.
Yeah.
So before we're running out of time, and I don't want to hold people up any longer, but I do have one more really important question I want to address, and it kind of fuses both of your agencies' work. What
Yeah.
about if you have a client who you're working with in the youth program, Malia, but
Mhm.
then they turn 18?
Yeah.
What happens?
It does happen. And so it's a strange transition sometimes because we're moving between our system and Glenn's system.
Mhm.
So we will usually close a crisis case when a child turns 18, but we're always connecting them with whatever resources may be necessary to continue to support them as a legal adult in
Right,
the
right.
community.
Mhm.
So we're connecting them, we're providing them the resource for adult mobile crisis. We have some resources, programs and things that we've referred to in the community, and we've also worked together with prevention and behavioral health services at times to look at other options when there's maybe some more extreme concerns in terms of like whether or not they have the right mental health support in that transition. Because I think that sometimes there's access for kids to some really high levels of care, and then they turn 18 and it's a whole new system,
Mhm.
that they're trying to navigate. So, trying to make sure those connections are made. I know that that can be a challenging time for
Right.
families because now we have a child who
Who's
is
now an adult. Right. But
um,
your team is there, it's just not a formal, case opened, right? Your team is there to help that family kinda make that
yeah.
transition, right?
Yes,
Is that
we're
yeah.
usually open with them and leading up until they turn 18, making all of those
Right.
arrangements
So
to
you're
try to make it
anticipating
work.
that transition, right?
Yes.
Which
Mhm.
is so important.
Yeah.
So Glenn, what happens next?
Well, I actually want to. I'm going to go
Tag,
back.
you're it, right?
Well, no, it's okay. I'm going to go back a little bit though, and
Okay.
try to. And then I'll cover the crisis portion, and then I'm going to try to talk a little bit more system
Okay.
wide
Sure.
about the adult system. But I will say that there are a number of times when our teams work cooperatively with Malia's teams.
Mhm.
Unfortunately, sometimes there are tragedies, particularly involved with schools,
Yeah.
where you have people under the age of 18 who are going through some trauma and crisis, and you
Yep.
have teachers and children who are
Mhm.
18 and above.
Yep.
There are sometimes family events that occur
Mhm. Mhm.
that are very traumatic, that really
Right.
require a
Sure.
large team to engage.
Yeah.
So we work fairly well together in terms of
Yep.
making appropriate referrals uh, when it is needed. Now, as far as crisis is concerned, if you are 18 or older, we are, ready and willing to respond. And that's, there's legal, parts to that, I think, in
Yeah,
terms of
of
who
course.
covers what population. But people
Yeah.
who, the day you turn 18, call, and even if you were to call Malia's team, they'll still say you need
Hmm.
to talk with Crisis, or we'll connect you
We'll
with
get you connected. Yep.
Crisis.
Right.
So, as far as crisis services go, it's not a real bumpy road in terms of the transition. Where the bumpier road can occur, as Malia was talking about earlier, there's oftentimes a wealth of youth services, particularly regarding housing, long-term programs, etc., that just don't necessarily exist in the adult system.
Sure.
And so, where the most frustration comes from individuals or from parents, etc., is when their child turns 18, and sometimes it can be a little after 18. The youth system may hold someone longer depending on a few different factors, but saying, oh, wait, we were used to having this service, but it's not there any longer. You can, not to say that adult mental health doesn't have services. We do have ACT teams and ICMs that provide case management. We also have group homes. I would say for anyone dealing with a child of their own that is coming up on 18, the sooner you can plan with their treatment provider for that change. When the planning goes well, referrals go to the eligibility and enrollment unit, which is a different part of adult mental health, but as early as when someone is 17 and a half years old,
Okay.
so that plans can be made and put in place for when that individual turns 18. There are times when people are in a treatment facility in South Carolina or wherever it may be, and we know that on this date they're coming back to Delaware. We go out of our way to try to make sure that those services can start for them as an adult as soon as they return. We have an individual that is, their primary role is on making sure that we have successful youth transitions into adult mental health or substance abuse services. And so while it can be frustrating, we do have services there, and we do have people there to guide you through. But it can be, for some folks, it can be a bit of a culture shock. I'll be honest, and Malia, I'm sure, has experienced this as well. You both know we get a lot of people that move to Delaware from other states, states with much deeper pockets and much larger tax bases. States, with
And bigger states, quite honestly, right?
bigger states with a whole lot more money and a whole lot more services. It's one of the things I end up explaining to people frequently is that you used to have a paid fire department. You don't have that any longer. One of the reasons for the property taxes being so low is is that there aren't quite as many services. I will say that we do our absolute best with adult mental health to try to meet the needs of everybody that we encounter as best we can. There are going to be times that people won't be satisfied with everything that is there to be offered.
Well, you're certainly working the best you can to offer it. I can tell from working with both of you over the last few years. I know that you put your heart and soul into what you do.
Well,
and
thank you.
we'll continue to work with you as NAMI Delaware, and we'll continue to advocate for services to grow, certainly, and also for people to know about the work that you're doing already.
Absolutely.
And to call early. I think I'm going to thank Wesley, give him a shout out for all the great posts he's provided during this conversation. And he cited something we mentioned, and it's a crisis is defined by you, and it's never too soon to call for help.
Perfect.
And I think that kind of wraps up what
Yeah.
we've said today, right? I mean,
Yeah.
certainly I hope viewers can get more information from our conversation, but in a nutshell, I feel like that's the heart of the message. And
Yeah.
with today's times, with all that is challenging for everyone, and for some more than others, and for some surprisingly so, out of nowhere, right? We have people who've sought mental health services that have never needed them before or have never sought them before. So they might really be on a journey they didn't expect to find themselves on.
Yeah.
So we want to make sure that we're there for them and that people know where to turn when they need help. So I want to thank you both for being here with us. And it sounds like we might need to have another conversation on transition age.
Yeah.
I think that could be a conversation separately, but we'll have to talk about that later. I want to thank you both again. And if you have anything else you'd want to say before we sign off, please do.
Just thank you for having us.
Yeah. Thank you.
Absolutely. Take care, everybody.
All right.
Take care.